Now, the one thing I want to really alert you guys to is a rare but known complication, and that's called Piyo Pneumothorax. And this occurs when a cavity that is sitting right underneath the pleura ruptures into the pleural space. So you get a collapse of the lung with pleural fluid. And the patient will present, they'll notice sudden dyspnea with or without pleuritic chest pain. And this is what this looks like. So if you can see on your left, there is a nodule in the left lower lobe, or a cavity, I'm sorry, and then you see afterwards. And this was actually a patient, a diabetic woman, who we had seen and kind of lost to follow-up, and she said in October, well, I kind of felt short of breath, and we didn't see her because she came in to her primary care physician, got a routine chest x-ray, which showed the image on the right, and so she was immediately referred to. So she had actually been walking around with this for months, just feeling a little bit dyspneic. So this is a classic presentation on the right, and if you see it, you've got a completely collapsed lung with an air fluid level. And again, if you're in Tucson or Phoenix, this is going to be a Piyo Pneumothorax due to cocci. This is the most common thing, and the importance is just to recognize this phenomenon. So we can see on the CT scan why this would happen. This is after she's collapsed, because we can see there's her cavity with an air fluid level sitting, abutting right against that pleura. Whoops. And that's why she just collapsed into it. Now, should that mean you should treat if you had someone with a cavity that was against the pleura? Should you be more aggressive? Should you do something about it? No. But it's important to just be aware that these cavities can do it. They don't do it commonly, but when they do, it results in this dramatic event. Now, chronic pulmonary coccidioidomycosis is actually relatively uncommon and was reported years ago by my friend George Sorosi, and I think used to be a more common manifestation. Now what we usually see is patients with chronic lung disease who then get cocci, and it just goes on and on. So how much is that the cocci and how much is that their underlying lung disease? But it is just a very persistent course. Here's a classic. We see this in histoplasmosis as well, patient with terrible lung disease and just persistent pulmonary coccidioidomycosis. So what about diagnosis specific to this issue? Well, most cases of pulmonary cocci are diagnosed by positive serology. Mike is going to talk about that. It is worth sending the lab a sputum culture. You should alert the lab that you are sending it for cocci, because cocci is a major laboratory hazard. Most microbiology laboratories in Arizona are very aware of this. They'll pick it up. We've had our lab pick it up on a routine culture. Cocci can grow. Our record is to see it in 2 days. But usually it grows in 3 to 7 days, and it'll grow on a blood agar plate. So the labs, and all the labs in Arizona are good at picking those up and taping the plates, but it's always nice to just let them know you're looking for that. And in fact, then they can do a fungal culture, which might pick up more cases. Obviously, if someone grows coccidioides out of their sputum, they have coccidioidomycosis. So that is a good diagnostic test. So what should you do if you see a patient that you suspect having pulmonary cocci? Well, of course, get a chest x-ray. As Rebecca emphasized, get a serology. I think everybody should get a serology for any kind of mnemonic process in Arizona. It's reasonable to try to get a sputum for fungal culture. If you can, do a first morning specimen, just like what we would do for tuberculosis. Often it's very scant, and as I mentioned, alert the laboratory. And follow up and repeat testing, as I think Rebecca alluded to and Mike will talk about, that the serology may be negative early, and repeated testing may turn up positives that were not initially positive. Now finally, treatment. Most patients with pulmonary disease, as I've already alluded, will not require therapy. And in our guidelines written in 2005, we listed these reasons: symptoms that are ongoing and not improving after 8 weeks, intense night sweats, a 10% weight loss, large volume of lung involved, prominent or persistent adenopathy, a very high serology, inability to work in older age. Those are all criteria that one can use. But I want to emphasize that most patients will not require therapy. And a study we did, which gets a lot of discussion because it was a case control study that Dr. Galgiani and I did in our clinic. And so it wasn't a randomized controlled trial. So of 105 patients with primary pulmonary coccidioidomycosis that had been referred to us, we decided not to treat 51 and we treated 54. Now, we decided to write this up as a study when my fellows came to me and was very impressed with how well patients had done that we didn't treat. He would see patients in clinic that we had never treated and they had done fine. The other reason we did the study is because we had been noticing clinicians were treating patients and recommending treating patients because it would prevent dissemination. And in fact, we knew that we had patients that we had treated and stopped therapy after a prolonged period for pulmonary disease that still disseminated. So we wanted to write that up, and that was the purpose of the study. Now, one of the points of the study is because it wasn't a randomized controlled trial, there were probably differences between the 54 we treated and the 51 we didn't. Probably the 51 we didn't treat were a little more healthy, not as ill. But in fact, when one analyzed that, it was hard to see those differences. Well, what did we find? That there were no differences in the rate of improvement between those we treated and those we didn't. That is, when we used a score of improvement, patients improved just as well without therapy as with therapy. None of the untreated patients had any complications, so that's just like the Valdivia study. We didn't treat them, they all did fine. But 2 of our prospectively followed patients, when we stopped therapy after prolonged courses, still disseminated. So our conclusions for that, number one, and this is the rule I have in clinic, if I get a patient referred to me and with valley fever and it's diagnosed and they're already improving, I do not initiate therapy. I just don't. I follow them. And I have yet to see a patient worsen. If therapy is indicated, what we have done is continue therapy for 6 months. There's nothing magic about that number. And then we follow that patient for at least a year. We have seen relapses, and in fact, the study I mentioned, we saw a lot of pulmonary relapses in people initially treated who were stopped. So you do want to follow your patient after, and you certainly want to follow your patients that you don't treat. And importantly, at least in our study, antifungal therapy did not prevent subsequent dissemination. So the way to monitor for that is to follow the patient. Patients who are going to disseminate will do that. Then you can institute treatment or restart therapy. But don't just treat a patient because you think that will prevent dissemination. It doesn't. Now, what about special hosts? And Rebecca referred to these. First of all, something I'm very interested in is HIV infection. When I first came to Tucson in 1985, I set up the HIV clinic at the Tucson VA, and we studied this. 41% of our patients got valley fever, and many of them died of it. We redid that study a few years ago in the effective antiretroviral era, and patients do very, very well. So the rule now is that patients, if they have a CD4 count above 250, I treat them as if they're any other patient. That is, I may not start antifungal therapy if they have primary pulmonary disease. So HIV patients have done much, much better. Now, pregnancy, we just wrote a paper for Clinical Infectious Diseases reviewing pregnancy, and the issues there is 2nd and 3rd trimester, and as Rebecca's emphasized, postpartum, pregnant women who've never been infected, who acquire coccidioidomycosis, get very, very severe disease. 1st trimester, much less likely, and women who already have had valley fever tend to do relatively well. The issue there was about use of azoles. Azoles are teratogenic, and what we tried to point out is that they're teratogenic in the 1st trimester. Interestingly, as that paper was in press, the FDA changed fluconazole from a category C to a category D, meaning you should really avoid it in pregnancy. But they agreed with what we wrote. That is, fluconazole should be avoided in the first trimester, but may be used after that. So that change in categorization, and I could never confirm this, but we think one of the reviewers was on the FDA panel, and he sort of woke up because the data are not that new. But the real important point is you can use azoles later in pregnancy. Patients with transplant, I think Janice is going to talk about that. And of course, TNF-alpha inhibitors are a problem. That's going to be discussed this afternoon. In most immunosuppressed patients, the default is to treat. Now, Rebecca has alluded to sex, age, and race, that males are more likely to get symptomatic disease than females, that the risk for symptomatic disease clearly increases in those as they age, and that African American men and probably Filipino men appear to be at a distinct increased risk. Now, the importance there is not that they should all be treated, but you really want to follow your patients who are African American or Filipino men with primary disease much more closely. I will tell you on the other side, when we do skin test studies, we have a host of African American men who we skin test, and they have a very strong response. So not all African American men have problems with cocci and do poorly. So it doesn't mean you treat more aggressively, you follow more aggressively. Nodules and cavities, I can't recall ever treating a nodule. I don't treat them. Cavities are treated if they're symptomatic, and they are sort of problematic in how they can do that. And certainly if they're large, I would consider surgical extirpation.